What you hear, you may analyze. What you see, you trust. A distorted image imparts a wrong message. To enlighten us on the tips and tricks in clinical photography in dermatology, we invite Dr. Feroze Kaliyadan, Associate Professor, Department of Dermatology, Sri Narayana Institute of Medical Sciences.
So, very good afternoon to all of you. At the outset, I would like to thank the organizing committee for giving me this opportunity to be a part of this wonderful CME. So I will be talking very briefly about clinical photography in dermatology, some tips and tricks which I hope you will find useful in your practice. I have no conflicts of interest to declare. Now, many times, when you see a good image, one of the common questions which people ask is which camera was used. Now, the camera is important, but what is probably more important is the person behind the camera. So sometimes, you may not have a really good camera, but you can still create wonderful images. And on the other hand, you might have a really great high-end camera, but if you're not really familiar with it or you don't know really how to use it, you will end up being like this, a traditional, like the Malayalam thing of Paragandailu Umala, garland in the hand of the monkey kind of thing. So one important thing is, whatever device you have, be familiar with it and be familiar of what you can do with it. Be aware of the capacity or capabilities of that particular device. That's one very important thing in any kind of photography. So like I said, the camera is important. So one of the questions which we often hear is, for clinical photography, which would be the best camera? And there's no clear answer, because we are spoiled for choice in the sense that we have a huge range of options available, right from our ubiquitous smartphone to high-end DSLR. So, and all of them have their own advantages and disadvantages. The smartphone obviously is handy, easy to use. Images are easy to store, easy to share. The DSLR probably has the best quality in terms of image quality, but is more bulky, difficult to handle, difficult to carry around. And you have a lot of things in between, like the simple point and shoot cameras. You have something called the bridge cameras, which come between point and shoot and DSLRs. And now you also have the mirrorless cameras, which are almost as good in terms of quality compared to DSLRs, but is less bulky, but has the disadvantage of being more costly and limited options in terms of lenses. So huge range of options. What do you need to look at while choosing camera? The most important would be the resolution. So each image, is made of small units, which we call pixels. And a million pixels is what we call a megapixel. So cameras, like we have cameras with 10 megapixels, 15, 20, and so on. For clinical imaging, the minimum requirement would be around 4 to 5 megapixels in terms of megapixels. In fact, there are studies which say that even 2 or 3 megapixels is enough. But the problem is that resolution does not depend only on the megapixel, but also the sensor size, which is in effect the size of the pixel. So just to illustrate, imagine that you have a camera which is 10 megapixel, but the sensor is small, while you have the same another camera with 10 megapixel, but with a larger sensor. So net result is that each of those pixels will be larger. So it conveys more information, more data. Net result being that it gives higher resolution. Now, it may not be a big issue in most cases, but sometimes, when you crop the images, you need to cut down or focus on one part of the image. That's when this comes into play. So point is that just looking at megapixels is not enough. You also need to consider the sensor size. And that is where the higher end, bigger cameras score over the smartphone. So in terms of megapixels, the smartphone may be even better than that of some of the DSLRs, but in terms of actual resolution, DSLRs still score higher. Why? Because the sensor size is bigger. So that's one thing. Second thing is the zoom. So zoom, you have the digital zoom, which is something like software generated zoom, and you have the actual lens zoom, the optical zoom, which is actually the real zoom. So the problem is, when you have situations like close-up images of the face, by default, smartphones only have digital zoom. You either need to use that when it leads to loss of resolution, or you need to go close to the lesion. When you go close to the lesion, it leads to this kind of a distortion. So to avoid this, you need to go back and zoom in. That zoom, you need to use the optical zoom to make sure that there is no loss in resolution. So that is where the optical zoom is important. Okay, so there's one area again where dedicated cameras score about the smartphones. And there are some other minor issues like something called flash synchronization, which is the time which the flash fires exactly, and something called the lens speed. In these parameters, also the smartphones are scored less than that of dedicated cameras. So the net result is that the chance of blur of slight blur with slight shake of the device is more with a smartphone as compared to a dedicated camera. So important things: the sensor size, megapixel, optical zoom. Ease of use is a big issue. So again, probably it does a little bit on a purpose. So if you're just taking images to share with your friends and WhatsApp group, take a second opinion, something like that, a smartphone should be more than enough. But then if you're looking at high-end publication, then you probably need to go for a dedicated camera. And of course, cost is one big factor, because the higher end you go up, the more is the cost. And even for smartphones having better cameras tend to be costly. So that's another thing which you need to figure out. And in the same context, to the question of can I use a smartphone? Well, yes and no, but the parameters which you need to consider are the same thing which we talked about. Okay, so you need to consider these things while making a final choice. Now, personally, what I do is that I have one of these bridge cameras. So the advantage of bridge camera is that, number one, it is compared to a DSLR. Number two, it has a pretty good optical zoom. And number three, the sensor size is pretty large. So it gives very good images, good zoom capabilities, much better than a smartphone in terms of image quality, and less bulky as compared to DSLR. So for most routine images, I just use this bridge camera. But for some very good cases which you feel that there's a chance of publication, I take an additional image with the DSLR. I generally avoid using smartphone cameras, but in some situations, when I don't have either of the other one, or the charge is run out of the battery in the other cameras, then sometimes I take smartphone pics. But in general, for most pictures, I rely on the bridge cameras. Okay, now coming to the photography part proper. In aesthetic photography, there are something which we consider to be important. And some of these are common to clinical photography also, like lighting and composition, for example. And something else which is very important in aesthetic photography is the timing of the images. Sometimes you need to be there in the right time, the right position to get a really good image, like this one. This was one of the awarded photographs in wildlife photography recently. And there are some, rules which we generally follow in aesthetic photography. So, for example, one of the classical rules is the rule of thirds. So what does it mean? So if you have a frame and you divide it into 9 equal parts with the help of 2 vertical and 2 horizontal parallel lines, the focus of interest, there should be ideally something in the image which is drawing your attention. And that particular thing should be not in the center of the image, but off center. And where should it be placed ideally? It should be placed at one of these intersection points. So you have 1, 2, 3, 4 main intersection points. And in this image, like you can see that it's over here. So that's one of the components of the rule of thirds. And there are other things like, for example, straight lines like the horizon and skyline should follow one of these lines and so on. So just to tell you that there are some rules in composition which are normally talked about in aesthetic photography. But having said all this, just take a look at this image. So you will see that it looks kind of dull. There seems to be no real focus of interest. It does not seem to be really following the rule of thirds. It looks quite plain. But this sold for $4.3 million. This is one of the costliest photographs in history. And if you ask me why, I have no answer. And I'm sure a lot of people have no answer, because it's a bit like modern art. Some things really just work and you really don't know why. So which is why we say that in aesthetic photography, the only real rule is that there are no rules. However, obviously, that in clinical photography, there are a few things which you need to keep in mind. One of which is really important, not directly related to composition, lighting and all, but is consent. Okay. So make sure that you take consent for all photographs. Now, I know that it's not practical to take consent for all images. So what you can do is that make sure that you have consent for at least images which you feel have a chance of publication. Now, there are 2 opinions. Some people they have a blanket consent which covers both things like a biopsy and photography. But in general, it is recommended to have a separate consent form for photography, which is which explicitly states that the photograph can be used for publication, presentation, and so on. Okay, so make sure that you take consent. Lighting is probably the most important thing in photography, because photography itself means writing with light. And the whole idea, to sum up, is that there should be good light, adequate, but not too much. It should not wash out the image. Now, in the case of manual settings, the lighting is determined by what we call the exposure triangle. So I won't go into details, but just tell you that there are three things which we consider. One is called the shutter speed. Second is the exposure. And third is something called the ISO. ISO is related to the sensor itself. It's basically something like a sensitivity of the sensor to light. Shutter speed, as the name suggests, is how long the camera shutter remains open. So obviously, the longer it remains open, the more light enters and the brighter is the image. And aperture is the diameter of the opening. So again, obviously, the more the diameter, the more the light enters. So basically, it's an interplay of these three things to get the best possible lighting, best possible exposure for the image. And a couple of points. Number one is that it's always better to use flash when you're taking an image, because it freezes the motion, so it avoids blur. But make sure that you're not going too close, or the flash is not too strong to kind of make the lesion white, to wash out the lesion. So that's important. And the second thing is that, of course, it's a good idea to have good ambient lighting in the place where you take the photograph. Now, coming to the actual framing part, we always say that it's easier to remember what not to do than to remember what to do. Okay, so what we'll do is we'll just look at some of the common errors or common issues which we see, and we'll see how we can address those issues. Okay. Okay. So the first image, image looks okay in terms of resolution. There does not seem to be any blur. It seems to be sharp. Now the problem over here, a few things. Number one is that there is a lot of empty space. So basically, this is the lesion. This is where you need to focus, but instead you have a lot of empty space here, which is actually wasting your resolution, wasting those pixels. So you can crop the image over here, but then you're losing pixels, you're losing resolution. So ideally, when you take the image, fill the frame. So try to fill the frame with the area of interest, and that helps you to avoid wasting a space or the need to crop later, which will lead to loss of resolution. So that's one thing. And the second thing over here is this is one example where you've gone too close with the flash, that has led to this kind of shiny appearance. And for that, you can use something to diffuse the flash, like a piece of tissue paper over the flash, or you can use dedicated flashes which are intended for this purpose, like a ring flash or a dual flash, which we will discuss later. Again, multiple issues over here. There is a distractor over here which looks pretty odd. The image looks to be a bit blurred, seems to be a bit of shake in the camera. Not properly focused the lesion. The lighting seems to be a bit poor. So a lot of issues going on. Now, again, like we said, we can crop it. So from the distractors, for example, we can crop it over here, but then you can see that, that leads to further pixelation, because you're losing pixels. That leads to the image becoming more pixelated. It will work if your image is really high resolution, but otherwise, as you crop closer and closer, you tend to lose resolution. So number one is the background. So make sure that you have a non-reflective, uniform, dark background. I prefer using black, but then you can use blue or gray. And for darker skin types, actually blue or gray is a better option. I usually, keep one of my wife's shawls with me, and I keep losing the shawls. So I need to buy her more shawls. But you can use a standard curtain, you can use a bed sheet, whatever works for you. Important thing is that it should be non-reflective. Second thing is that the lesion or the area to be photographed should not be very close to the background. That tends to create shadows. So you need to keep a gap of around half a meter to a meter, so that there are no background shadows created. To avoid blur, flash is more important is to stabilize tripods and monopods for both delicate cameras and smartphones. So try to use those. And another thing which is really useful is a remote release switch. So we have these small remote camera shutter release options, because sometimes when you press the camera, even on a tripod, it can shake a bit. So to avoid that, the remote release works really well. So you always use a stabilizing device like a tripod or any other stand which you can use to avoid the blur. Lighting, like we said, the simplest thing is to have good ambient lighting. In dedicated studios, you have these soft boxes, or for small lesions like the mucosa, you can use these ring flashes, dual flashes, and so on. That will help to ensure enough light, but without creating too much of harsh shadows and reflections. For the mode, it's always better to use the auto mode, especially if you're not really familiar with the manual settings. So whether smartphone or a dedicated camera, try to use the auto mode with the flash on, but then try to also take images with and without flash so that you see what works best. So in this case, what we've done is we have used a uniform background with distance between the lesion and the background. Flash is on, but we made sure that the flash is not too close, so it's avoided brightening out the lesion. So in general, this seems to be a better image as compared to the first one. Okay, now the problem here is that the image looks good in terms of resolution, it looks sharp, lighting is okay. The problem is that there is no sense of position. It's difficult to really make out where the lesion is. Now you can use a description, but a simpler thing is to include an anatomical landmark. So always include anatomical landmark for localized lesion, and that gives you a better sense of position. This is something we should discuss before. So when you use a smartphone, especially for a close-up image of the face, and when you go too close, it creates this kind of a distortion. So you need to go back and zoom. Again, this works best when you have optical zoom, not digital zoom, because digital zoom will lead to loss of resolution again. For generalized lesions, it is always good to take one zoomed out image showing whole extent of the lesion, one medium range, and one close-up to get an idea of the morphology of the lesion. Now, before and after is one area where we always have problems, because before and after needs to be consistent. So as an example, these images were taken within seconds of each other. Only difference being that here the normal camera flash was used, while here external light with the soft box was used. You can see that it's much softer, it looks much better. But here the lesions are actually much more clearer. Okay. The point is that you need to standardize before and after images in all aspects. So lighting, camera position, zoom, patient position, distance, all should be the same before and after. A simple way of doing this is to create a position or a point in your clinic where you photograph patients and mark out areas to place the camera using scotch tapes, and maintain a standard parameter for your camera, which works for most images. You can also use frames. Some of these frames are quite costly. So these are especially used for facial images, for cosmetics, in the context of cosmetic procedures. You can actually make frames by yourself. So there are different options, but the simplest thing is, create standard position points for your patient in the clinic, shoot from a standardized distance, and maintain standard parameters for your camera. Usually that is good enough. There are also something called overlay software, which is available for dedicated cameras and for smartphones. We actually have made one, which is available on Play Store, something which you can try out. So the whole idea of this is that when you have the pre-image, that image acts like a shadow or a transparent template through which you can shoot the post-image. Okay. And the shooting parameters, the XF data, the parameters like the aperture size, the exposure and all are imported from the first image, so that a lot of things are consistent. So you get better pre-post images. So these are called overlay software. So just to sum up, fill the frame, avoid waste space. Very important is to use a uniform, non-reflective background, remove distractions in the background. Shoot perpendicular to the lesion. That helps to avoid unnatural angles and sharp shadows. Stabilize the camera, use flash, use a tripod, but then make sure that when you use flash, don't go too near to avoid overexposure. For localized lesion, try to include anatomical landmarks. For generalized lesion, take zoomed out and close-up images. And for facial images, make sure that you use the optical zoom. So go back, zoom in, don't go too near without zoom to avoid distortion. These are some of the common issues which you need to address. Now, special sites, I'll just talk about the nails, the hair, and the mucosa. So for the nails, one of the issues is that the nail is a very reflective surface. So one thing you need to do is that the flash needs to be kind of tempered. It needs to be you need to make sure that it is not overexposed. So simple ways of doing it is that you wrap a piece of tissue paper or butter paper on the flash. You can do it from mobile phones also. For dedicated cameras with a inbuilt flash, you can use something called a flash diffuser. Again, you can buy a flash diffuser or create one using some cylinders. The best thing, of course, is to use a ring flash. Again, we have now ring lights for mobiles also, but they don't work as good as the ring lights for the DSLRs. So the advantage of these ring lights is that it gives light, but without giving a sharp reflection on shiny surfaces. So this is using a ring light. So here you can see that when you get too close, it brightens out the lesion. While here, because of the ring light, there are no sharp reflections. For nails, there are a lot of articles which talk about standard frames, where you can eat all the nails if you want to. And that is, you can just go through those articles. I will not be discussing in detail about them. For hair also, there are some standard frames, especially when you're talking about generalized hair loss. So a minimum we include is of 5 frames, 2 from the side and 1 from the back and 2 from above and 1 from the front. Again, for the hair also, it's a very reflective surface. So the use of soft boxes, the use of flash diffusers will help to reduce the sharp reflections. Oral mucosa is very difficult to sometimes photograph because there is not sufficient light reaching that area. And one of the ways to overcome this is, most of these cameras, they've got something called the AF assist beam. This is available in compact cameras also. So, basically it's something like a light which helps to focus your camera. So this beam can be focused on the area in the mucosa, and then you take the image. It's a bit difficult to do it because you need to play around a bit to get the right position, but once you do that, it tends to give a sharp image. So this is using the AF assist beam. Or a simpler thing is to use a pen torch. So you just simply use a pen torch, you focus that on the area of the mucosa and take the photograph with the flash off. Okay. So that also works good enough, but then in this case, you need to really stabilize the camera because even a mild shake can lead to blurring. And in the oral mucosa, again, always keep in handy some things like a tongue depressor or retractors to get better images. And here also, ring flashes and dual flashes are really useful. Children can be difficult to photograph because sometimes it's difficult to make them stay still. So use distractions for the children, say like a rattle or something of light. Use flash always, and if you have manual settings, use a fast shutter speed. And very important is to be patient. Okay, so you need to take multiple images to really get good quality images which you can use. The single most important tip for clinical photography, or for that matter, for any photography, is to take multiple images. Now we don't have the issue of paying for film rolls and for development of the film. So, you can just simply keep on shooting as many as possible. Later on, review those images and keep the ones which you feel are good. Okay, so simplest, the most important thing is to take multiple images. Cataloging, editing are 2 things which we always need to discuss in terms of the clinical photography, but we don't have time to go into detail into that, but just a few points which I would, consider keeping in mind is number 1, try to save the images to folders each day. So make a folder on the computer for each patient, try to save it each day. And in that same folder, you can combine pics from different sources. So dermoscopy, histopath, later on, if you have the, the documents, imaging and so on, you put it in the same folder. When you label the folder, use a standardized folding labeling format, whichever works for you. But the minimum things to include would be the name of the patient, the hospital number, the date, and the disease condition itself. And why this is important is that, unless you write the disease condition, you may not be able to retrieve images of particular conditions. So, for example, if you want to retrieve all images of psoriasis, unless you've labeled it accordingly, you may not be able to retrieve it properly. So make sure that the disease, name, hospital number, date are the minimum things which are included in the labeling of the folder. And you can actually label this using tags, both in Windows and Mac. That again is something which probably needs a slightly more time to discuss, but something which you can try out by yourself, using tags to label folders and files. And of course, very important is to make backups. I'm sure that all of us at some stage have lost images or files in general. So make sure that you have at least one backup on a hard disk and at least one backup on a cloud. Something like a G drive can be used as a cloud backup, so that in case even if you lose images from one point, you still can retrieve it from some other backup source. So just to sum up, so when we talk about clinical imaging, probably the most important things which you need to consider are framing, or composition, the sharpness of the image, so focus, avoidance of blur, resolution, and lighting. Framing, important thing is to fill the frame, avoid waste space, use a non-distracting, uniform, non-reflective background. Don't go too close to the image. Instead, use optical zoom. So you go back and zoom in. Standard frames in the context of hair and nail. Pre-post image, all aspects should be similar. So zoom, camera parameters, patient position, camera position, all should be the same in the pre and the post to ensure that the image is standardized. To make sure the image is sharp, focused, and blur is avoided, use a tripod, use flash, but make sure that you don't go too close when you use a flash. And ideally, if you're not familiar with manual settings, use auto mode. Resolution is more of a camera property, but important things when you choose are the megapixels and the sensor size. And one tip is that use the maximum resolution that your device allows. Okay. Although it will lead to a larger file size, but nowadays storage is not a big issue. So as far as possible, shoot it max resolution. Lighting, very important. So you can use available light, you can use inbuilt flash, external flash. If you're using manual settings, exposure triangle, shutter speed, aperture, ISO. And flash again, make sure that you don't go too close to the lesion. Avoid washout or overexposure. Some other important tips: take multiple images, archive backup properly. So use at least one hard backup and one cloud backup. And we don't have time for this, but basic editing is very important because sometimes no matter how much you try, you get an image with problems. You can correct a lot of those issues by post-processing, by editing. And some of these edits are quite simple, and a lot of these things are available online. So that's something which probably we can discuss in some future session, hopefully. So thank you so much, and I hope that that was useful for you.
Thank you, sir, for that wonderful presentation. Now, Dr. Seena brings us words of wisdom from Sadeep, sir.
Hello, good morning to all. Now I am with Sadeep sir to speak to him about his experiences.
It is very not lovable memory, but we had some sort of hardships because everything is for a well education and quality of the MD examination as well as the service as a lecturer in the medical colleges. So in order to keep a very good standard, he always give a lot of assignments and presentations and paper presentation, case presentation. It's every third month I have to present a lot of cases and as well as case presentations in a lot of regional clubs, his own clubs, and he don't smile during our teaching hours, but as an examiner is very, very, very encouraging. That gives a lot of encouragement and confidence. For example, for the diploma examination, it was not ready to allow me to write the examination. After a big play, he allowed me, but on the time of examination, I didn't see the smiling face in my lifetime. He encouraged me like that. ഈ മലയാളത്തിലാണ് പറയുന്നത് മിടുക്കൻ നിനക്കിതിനെ കഴിയും ആ ഒറ്റ വാചകം മതി. So I thought that I will absorb all his good qualities and I will delete or avoid all his bad qualities like short temper. That is why I behaved like a person like this, loving to all staff members, PGs, and colleagues. I never showed my um, rough face into you people. Can you recognize it? Remember that? Yes, that is right. So, I made it alternate way that you love them. They love you. In return, they will work hard to give a presentation like the top levels in the dermatology. That's it. Thank you.
Thank you, Team Dermatology CMC Chalaka, for this opportunity.
In our last video in Meet the Doyens, Dr. Sindhu meets Muhammad sir.
Hi all, a very good morning to you all. Today is a very pleasant day because I am with one of my great teachers. Dr. Muhammed sir is a great teacher, a very lovable person and a man of green. Sir was head of the department and professor, Department of Dermatology, Government Medical College, Calicut, and is presently working as professor and HOD, MES Medical College, Perindalmanna. Welcome to you, sir.
Welcome, Dr. Sindhu, my favorite student. And also I thank the Alumni Association for giving me this opportunity to talk to you.
Sir, can you please share your experience as a teacher, teaching generations of students?
Okay, one example is in front of me. And I was very satisfied with my all the batches of students. And also I sacrificed my life in teaching students and molding them to be a good dermatologist.
Sir, you are a great clinician and you always teach us about common things. That's a very practical teaching by you. We always remember, we are always thankful to you, sir.
So we should actually teach how to diagnose cases and how to manage them in their future life. That was my motto.
Sir, do you have any message to the next generation of postgraduates in all this techie world?
Yes. Our instrument is the patients. So give due credit to them and their dignity, and you should help them. So that, and also you should have a good rapport with them, so that you can extract all the history and you can examine them without any hesitation. So even being a man, I never find any difficulty to examine a female patient if you establish a rapport and if you have some chaperone with you. So and nowadays most of the dermatologists, I have seen some boards, don't blame me, as cosmetologist. So no dermatologist is a cosmetologist. You should be a cosmetic dermatologist, or you should be an aesthetic dermatologist only after diagnosing, then only you are going to treat the cosmetic problems. So cosmetology means a beauty parlor. So my one of my messages, you should not put a board like cosmetologist, because this is not our field, and there are reports of quackery also. So we should not do quackery. You should be a clinical dermatologist first, then only you become a cosmetic dermatologist. Otherwise, how can you then? There is no difference between a beauty parlor and a dermatologist. Okay. And also we also think about the quackery. Are we doing any quackery, like infiltrating to any other field, like the plastic surgery, the vascular surgery, the psychiatry, etc.
Primarily, we are all dermatologists.
We are all dermatologists.
Not cosmetologists per se.
Yeah.
Okay, so that's a great message you have given. I have a small gift for you, sir.
Okay, I am ready to accept. Thank you.
Thank you, sir.
Many things that bore much importance to previous generations are of little significance to today's youth. But one thing that remains unchanged is the desire to look beautiful. As the final program of the CME, we have a panel discussion on cosmetic dermatology changing trends. To introduce the panelists and to moderate the session, we invite Dr. Abdul Latheef, Professor, Department of Dermatology, Government Medical College, Kozhikode.
A very good afternoon, everybody. Hope I am audible.
Yes, sir.
Yes, yes. This is the last program of our today's meeting. So today we are planning to discuss few areas regarding cosmetic dermatology. My colleagues and friends participating in the discussion is just a friendly talk rather than an official panel discussion. So we have got eminent personalities in the group discussion. Dr. Meera James, she is an authority of cosmetic dermatology in Kerala. Not only Kerala, conducting various programs in India and internationally. And Dr. Jyothy, she is an alumnus of Calicut Medical College and one of the brilliant students of Pavitran Sir. And she is doing various cosmetic procedures for last many years and working in Coimbatore. And she is a member of the DVL laser SIG group also. And Dr. David Pudukkadan, I think he's an MBBS he done from Calicut Medical College. So again, an alumnus and a very renowned person in the field of cosmetic dermatology. And Dr. Geetha, she's again our student and doing cosmetic dermatology practice very widely in Calicut and one of the very good students of our department. So we know over the last decade, many changes happened in cosmetic dermatology. The demand is increased. And I remember 10 years back, there were only few cosmetic dermatology clinics in Kerala, especially in Calicut area. But now there are many centers that indicates the demand is increasing. And previously, there were the treatment given for mainly some skin lesions that is producing some difficulty to the patients. But now, I think the trend is changing. The people want a youthness and a good-looking face, and especially the concept of the beauty is increasing. So many ideal cosmetic concept is increasing, and people want an ideal self rather than a natural self. So that is increasing. So many procedures we are doing in our practice. So that indicates the significance and importance of cosmetic dermatology. And I still remember one postgraduate came to my department, and she was actually influenced by one of the panelists, especially Meera, and she was the influencing personality to take dermatology. So the current scenario, so many procedures we are doing. So today, I would like to have just a group discussion and not an official panel discussion like thing. I'm showing few photographs and we can discuss the various aspects of this management. It's a vexing problem even now for the dermatologist. Melasma That's a very common problem. So in this group, we are doing so many procedures and so many things. So I would like to know, and you can share the knowledge with our colleagues in this group. So melasma is a very, very common, and it is very difficult to treat problem. Even if we are treating, there is chance of recurrence. So Meera, how will your mode of approach in the case of melasma? Will you directly go to the treatment or investigate, or will you give a topical therapy, or will directly take for a procedure? Your mode of approach in melasma?
Initially, I give them topical treatments only because most of the time now, when the patients come to us, they must have taken multiple treatments. They must have even used the triple combinations that must have made their skin very sensitive. So if we are starting with a procedure or something, we don't know how we are going to irritate the skin. So I would always tell, like, okay, never start a procedure the first time when we meet a patient. And always we have to tell them melasma is a problem which we can never completely get rid of, because we know, like, whatever we do, okay, we can give them relief for some time, but most often they are going to come back with the problem. So we have to actually sit and talk with them, make them understand it has got multiple associations, multiple things, and some treatments would be effective for some patients, but for some it wouldn't be effective. There are a lot of patients who would come and tell us, like, okay, doctor, why couldn't you do a laser and get rid of it completely? So laser, for a time, people were thinking that laser would work for it, but like, okay, laser also doesn't work. Some pills do work, like, okay, the newer combination pills would work, but again it comes. So it's actually a combination that works better. So what I have found is, now I don't do any laser for melasma, but I have found tranexamic acid tablets actually giving good results. So I give a combination. So definitely I start with the like topical treatment, understand the nature of their skin, then, like, okay, even start them on tranexamic acid tablets, and may start peels or even mesotherapy. Some of these mesotherapies, newer introduction, like the glutathione mesotherapies, also work to an extent. That's my approach.
So mesotherapy or injecting to that area?
Yeah, mesotherapy, we can do it in multiple ways. Like, we can actually do the mesotherapy by using the meso rollers, or we can actually inject it. So there are multiple, like, okay, the microneedling kind of techniques. So varying from person to person, but most often we can do it with the microneedle, like, okay, pen or even injection.
So you're not happy with the peels or lasers? You're not happy with these modes of procedures?
Lasers, I'm honestly not happy, because like, okay, the Q-switched NDR lasers may give effect. Like, okay, I have a Metlite, like, okay, which I had been doing for some patients. Okay, it works, but even then, after some time, you start seeing the pigmentation slowly coming back. I find the combination pills like the Melaspil Kachan, which are the combination of multiple pills, giving more effect.
Okay, Dr. Jyothy, I want to hear from you regarding the same area. Dr. Jyothy? Jyothy, you are muted. Please unmute.
Muted. You are muted.
Okay. Sorry for that. Good afternoon, everybody. I agree with Dr. Meera that melasma is still an area where actually we get frustrated while treating the patient, because most of the time they want a permanent cure which we can't offer. So that is the main thing. But I still believe that hydroquinone plays an important role. Whatever number of webinars you conduct, still hydroquinone is still the workhorse. So the role of lasers, if you ask, maybe we can say we target the vascular component sometimes. Like if you do a dermoscopy, you see some patients having prominent capillaries or telangiectasia like picture. There we have a role of pulse dye laser. Sometimes we can combine with a very low fluence Q switched. But most of the time we don't push the patient into these procedures, because ultimately we will end up in trouble. So it's better always to have a combination of medical management, then maybe go with the peels or PRP or mesotherapy.
So Dr. David, have you anything you want to add in this area?
Can you go back to the picture, sir?
Hello.
Actually, I think
Yes,
it is a
some sound
combination of
problem.
three things.
Yeah.
It's not clear.
There is some clarity
Hello?
problem with your sound. Okay, if you have any problem, Geetha will be answering the same and you can come later.
Sir, good afternoon, all of you. Sir, I'll always follow the age-old method. Like I'll have to find out whether it is epidermal, dermal, or mixed by using our old wood lamp always, because I always feel the epidermal resolute has got the chances of resolution on its own, but mixed and dermal, very less chance of resolution. Has already been told by all. None of the methods. I'm very much afraid of using the Kligman's regimen because most of the patients continue using it for a very long time. Even if we ask them to stop it, they never stop it. They use it for more than 1 or 2 years. So the other, I only always resort to topical medications, the new things which are coming, the arbutin, glutathione, like ma'am has already told, the tranexamic acid. I also give glutathione tablets also. And I'm also very apprehensive of using the lasers because, as Jyothy madam has said, there is a vascular etiology associated in melasma. I think madam has only used the pulse dye laser because it's available there. Because I have seen Tajuddin sir having the PDL, so that can be used to reduce the vascular component. And I'm also very apprehensive about using lasers because melasma is something which can resolve on its own. So it is always better not to touch it because it's a long procedure, because it usually has a psychological impact on the patients whom we should not tax much.
So what Geetha's mentioned is a very important thing, because many of the time what's happening is if you are giving the medication, even if we are telling to stop after some time, they will be continuing it for a long time, and they will come back with telangiectasia, erythema, and all these problems. So Dr. David, so you just tell me regarding this other skin lightening agents other than this Kligman regime and all, what's the use in your practice and what's the advice you have to give to the general dermatologists? They are not doing any such procedures. David? Dr. David? So Meera, you can take the question.
Yeah, the other hypopigmenting agents, because now the fad of like fairness is there. So patients do come with like, okay, demand for entire body, like, okay, entire body, like lightening and all those things. So like, okay, we know like there is kojic acid and all the newer and newer agents are coming, even curcumins and these things. So what happens is, as Dr. were saying, like, okay, definitely triple combination works, but there is always the limit of like, okay, the patients would overuse it. So we always need to actually like, okay, combine. Many a time what we see is like there are patients coming using these triple combinations for long, and we cannot actually suddenly stop it, because what happens is the moment we stop it completely, they again start getting the pigmentation and they actually leave us and they would go this again start treating themselves. So we have to actually taper it. So for that we have to actually combine it with another hypopigmenting agent, or like, okay, that again depends on what the patient's problem is. So the newer hypopigmenting agents are working really good. So we have even got these glutathione gels are there, then the acetic acid, to so many things are coming. Some of them are effective, some of them doesn't work. Even vitamin C, we all know it's a good antioxidant plus anti-inflammatory and everything. Some of these vitamin C preparations are really good, they really work, some doesn't work. Even the retinol creams, we know, like, okay, retinol serums are available. So it all depends on like, okay, how we want to place it and what exactly is the patient's problem. If a patient wants an anti-aging added to the hypopigmentation, retinol creams and serums work really good. So that's a kind of thing. So, and then like, okay, for an entire body, like the lotions would be better. So that is how.
In this discussion, one thing we realized that melasma needs a psychotherapy rather than a cosmetic therapy. That is better, because
exactly
persisting there for a long time and the patient needs emotional consolation. That's important.
So I think that
yeah.
take
The
over.
pediocular pigmentation, that's also very, very common. People are coming for treatment of that area. So anybody can pick this question, what mode of therapy you are usually adopting in pediocular pigmentation? Jyothy?
Hello, can you hear?
Yeah, you can continue.
Yeah, periocular pigmentation like melasma is again a tough thing to clear completely. So we actually approach depending on the cause of the pigmentation. Actually, it may not be pigmentation. As we all know, there are three main reasons for this type of what people call it as a dark circle. So if it's an actual pigmentation which is causing the problem, then we can lighten it. So starting with the medicines, we go with the peels or other procedural management according to the cause. So if it's a pigmentation, we have to manage like any other pigmentation. Only thing is we have to be careful while handling the sensitive area around the eyes. So if it's only pigmentation, it's easier to treat. But most of the time, people will have multiple like factors leading to the appearance of dark circles. So if it's a tear trough problem or a structural alteration of their orbit, then we can't just manage with the skin lightening creams or the lightening, like reducing the melanin.
So will you
So there
investigate?
we approach with the dermal filler for the tear trough correction. Then if there is any vascular component, again we have to manage that also. Sometimes the skin may be thin and that blood vessels may be slightly prominent, giving a darker shade. So all these things we need to consider while approaching the dark circle in a patient.
Dr. Meera, will you do any investigation before starting treatment in these cases? And anything new you will offer to the patient other than the pills we are giving for many years now? So anything new you have to offer in this
The
field?
thing is like not every case I wouldn't investigate, but we all know like okay, there is an element of pseudo acanthosis nigricans also can, or acanthosis nigricans can, and the insulin resistance can lead to this kind of like okay pigmentation around eye. So in some cases I do investigate, but other than that, the newer thing is there are these kinds of with the regenerating fillers called the I would take a name that is actually something called volate, which is actually plain hyaluronic acid. So it's actually something which when we inject, it helps to hydrate as well as fill. We can even immediately see the result. This is something I have found very effective in the treatment of periorbital pigmentation, because periorbital pigmentation, as Dr. Jyothy was mentioning, it's a combination of multiple factors. There is pigmentation, there would be wrinkles. Sometimes we even need to do mesobotulinum toxin injections added to the filler, but the filler alone sometimes wouldn't be giving that kind of pigment reduction. So these kinds of hyaluronic acid alone filler, there are so many of these booster injections available, but for me, like okay, the one that I found most effective was the I am not a fan of Allergan honestly, but there this product, the volate, actually works there. If you give it a small multiple injection, it actually reduces the pigmentation, hydrates the area, and gives very good results. But again, you have to go for a combination. Sometimes the skin would be very lax, adding on to all the problems. You may need to tighten it with a thread lip and then like do a botulinum toxin, then at a later sitting do a filler injection. So it actually needs to be seen and treated. And in every case, the investigation won't be possible because there are patients who wouldn't actually like to be investigated too much. They would say that, Doctor, I want a solution. Like, okay, tell me what you can do immediately. I want to look good for some function or something. So that's the case.
So what about the durability of the response? We are doing multiple procedures and earning some earnings now. That is the importance of cosmetic dermatology. And so what about the durability of these procedures? Means the clinical response.
The durability, the thing is like, as we all know, like, okay, these procedures, the effect of a botulinum toxin injection lasts only for 4 to 6 months, whereas the filler injections can last for 8 to 9 months or even 1 year. Whereas these meso injections of fillers, they would last maximum around 6 months. We may need to repeat, but if in a younger patient, we would actually see the results lasting longer.
Look, David is
there.
David?
Yeah, you can add. Yeah, can you hear me now?
Yeah. What advice you have to give to the people? Can you hear me?
Yeah, I can hear you.
Yeah. So what advice you can give to the general dermatologist, because they may not be doing peeling, all these procedures. So in the management of this dark circle.
Basically, we think about 4 things when there is a dark circle. One is the actual pigmentation. Second is a wrinkling. The third will be a loss of volume, and then the vascularity, increased vascularity. Or basically, it is a thin skin and the periorbital area. So pigmentation you can treat with a lightening agent, which is a mild lightening agents. You cannot use hydroquinone in those areas, which can irritate the periorbital area. So the usual scenario, you treat with a lightening agent around the eye. So that is one thing you can do. Then we talk about the wrinkles, which you can correct with, as Dr. Meera said, botulinum toxin, mesobotox can help. The second is PRP and PRF, which you can add. Hyaluronic acid, plain hyaluronic acid like Volite can actually hydrate the skin and improve the wrinkling part. So that is another part. The third is improving the volume with a filler. Or you can actually tighten the skin using a radiofrequency tightening device or a HIFU. So all this can be done. Vascularity is an area where it is difficult to treat. The superficial vascularity may be masked by using a filler. You put in the hyaluronic acid or PRP. That might mask the superficial vascularity, but prominent vessels may not be masked by doing those procedures. So you can start with a lightening agent, ending with a filler or a Botox or even the procedures.
Okay, thank you. Now we can come to the acne scar management. This is also one of the vexing problem to the dermatologist. So this type of scars, the patient is coming to you. So how will be the mode of approach in your practice, Dr. Geetha?
Whenever I see an acne scar, I try to divide it what kind it is, whether it is ice pick scar, box scar, or macular atrophic, and all the different kinds. The usual kind of treatment which I would start with is depending upon the budget of the patient also. I initially would like to go in for peels. The age-old method, our punch, excision, and elevation. I would try all that with people who can't provide much of funds. Then I would like to always go in for our subcision. I always feel that subcision is very good. We can go in for dermabrasion. It's like an algorithm which is followed step by step. Then it is always good to try out peels, especially glycolic acid about 20 to 35%, TCA of about 10 to 15%. Then I would.
That depends upon the type of the scars, no?
It depends upon the type of the scars.
Peels will be highly useful in superficial scars.
Yeah.
But in cases with the deep scars.
Depending upon the scars. If it is a deep scar, I would feel that instead of the ablative and the ablative lasers can be tried, like carbon dioxide laser. But these days, I would always go in for MNRF, because I feel that MNRF is not color coded compared to the fractional lasers, because MNRF doesn't depend upon the pigment. I feel that South Indians, because of the pigmentation, whenever these lasers are used, because the earlier laser which had come up was the carbon dioxide laser, then came the erbium YAG laser, then the pixel. What happened, what I found by using these lasers for all this is because in our South Indian skin, because which we are pigmented, because all these lasers usually causes post-inflammatory hyperpigmentation, and they require enough downtime. I found MNRF easier because I could explain to the patients because it never required much of downtime and it is colorblind.
So, Dr. Meera, what is your mode of approach in this case?
I would do fractional CO2. What was said and done, okay, pH is a huge problem, but even then I have found fractional carbon dioxide doing the best in these kinds of scars. It actually, irrespective of all the scars or whatever be the type, ice pick or box or whatever be it, like, okay, the fractional CO2 works really good. And nowadays I actually combine mesotherapy together with it. That is in the same sitting. I would do a fractional laser combined with the mesotherapy. And then actually I ask the patient to like minimize the sun exposure, give them proper sun protection, and give them even a little bit of steroids for the initial few days. And I have found very good results with this.
Peels and micro needling in this acne scars?
Peels and microneedling, the thing is, like, very honestly, peels doesn't work much in the case of scars. So I don't do much of peels for scars. Microneedling, okay, it works, but when you compare, the thing is, like, the fractional CO2 gives results more or better than microneedling. So I don't do, but as I said, like, okay, in some cases I like, okay, combine microneedling and fractional CO2 even in the same city, and I get better results, but it's more of a risky procedure. So a person who is starting their practice initially shouldn't attempt doing or combining too many things in a single sitting. Always it's better to, like, okay, you can do a fractional CO2 in one sitting, and in the next sitting, maybe you can do a microneedling. That way also you can do, and you can get good results. And sometimes the
Dr.
Yeah.
Jyothy, what advice you will give to the patient to prevent this type of scarring in your clinical practice?
Usually we ask the everybody who comes with acne itself, we tell them, see, treating acne is easier than treating acne scars. So whenever you develop acne, don't resort to home remedies or self-treatment. Consult a dermatologist as soon as possible so that you can save some money on treating your acne scars. That
So
is
we
the
need to
advice
start
we used to.
isotretinoin or other like a
Yes, definitely. Once they reach the dermatologist, then the doctor will handle it properly, no? So depending on the severe scarring, we approach. So at least patient should consult a doctor for that. But nowadays, acne anybody can diagnose. You don't have to go to a doctor to know that you have acne. And the internet is filled with all sorts of remedies. So to save money, at least few rupees, they won't consult the doctor and resort to all these treatment modalities. You cannot even call it as treatment. Some sort of gimmicks they are showing to get the viewership, and then these people will blindly follow it.
The
So
important
most of
message
the
is
people, they will be using a steroid combination, which is the shortcut to get rid of, at least for temporarily. So we tell them, and one thing I would like to add regarding the acne scar management is, see, we should always remember that there are only four ways of approaching a scar. Either you have to do a resurfacing, you have to do filling, you have to do excision, or you have to do lifting. So these are the four ways of improving any sort of scar. So how we approach is,
these cases, no?
pardon?
Depending upon the situations, we can opt
Yeah,
this case.
depending on the situations, these are the approaches. These are the ways of how we approach a patient, like resurface, refill, lift, or excise.
So the important
So,
message of this discussion is that early treatment, that is very important rather than treating the acne scars. That is the important message we have to give to the patients.
and because we are one more thing, because we are discussing recent development, even though it's not a very recent development. So when the patient comes, we stretch the scar and see, and if there are some additions, whatever method you do with MNRF or fractional CO2 will not give you that much result if not that bands are released. So instead of going for a subcision, we have this RF subcision, which I have found is very good compared to a subcision. So we start our treatment with RF subcision first. So there is absolutely no downtime, and the result will be very good.
So
Can I
whatever
add some
treatment you
point?
are giving, you won't get a complete normal state, and you can improve up to a small extent. That is the message we can give. Now, due to the positive
Can I
time, I'm going to the next topic because time is, we have few more topics to discuss. So this is a triad distance, very common, especially females coming that they are ready to be pregnant but don't want a stria on the abdomen. So how can we prevent and treat this area? So Dr. David, so how will you advise the prevention and how will you manage? What is the usual mode of management in stria distance?
I don't think any material will reduce or avoid the stretching or the stretch marks, but it all depends on the stretching which has happened on the skin and the type of skin the patient has. The patient has a tendency for stretch marks, he's going to get it. So the only thing you can do is to treat it. What I usually do is patient is very I talk to the patient because treating stretch marks is one of the most difficult thing which you can do. If the patient is really motivated, I start the patient on radiofrequency microneedling. That is the only one which will go that deep to correct the stretch marks, in addition to PRP or micrografting, the so-called regenera procedures, which is available. And
any
combination of
this, David, any topical therapy?
Scar gels I used to give, but I didn't see any difference. Actually, even though we talk about procedures, most of the patients are not willing for any procedures.
Retinoids, your experience regarding retinoids?
I don't see, because pregnancy time retinoid, even topical retinoids are not recommended. I used to give hyaluronic acid.
Other situations also, not only pregnancy. Other youngsters will be
I used to give hyaluronic acid gels, which is somewhat better. Even the scar gels, the Alliance extracts has some effect that gives around 10 to 20% improvement. So that can be given as topical agents. I don't think other agents work as well. Even peels can be done.
Meera, have you anything want to contribute in this area? Anything new thing?
Yeah, the thing is, like, I have found Q-switched NDR glazers working really good for the like the stretch marks. Actually, you can do a Q-switched NDR glazer and then apply silicone meso solutions and then wrap it around. That is, there are these cling films which we use to wrap the food. So you can do a Q-switched NDR glazer. The stretch mark would immediately turn red. So it produces those or opens up the skin pores. Apply the meso solution, which would penetrate, or the meso solutions can penetrate better with that, and then wrap it around, leave it for 24 hours. And I have found very good results with that.
So what is the content of the meso solution you are using?
It's a silicone meso solutions. So silicone actually promotes collagen reorganization and skin regeneration. So that actually promotes the skin and skin healing. So I find the stretch marks actually reducing in size, and it merges better with that. We can never treat the stretch marks or the scars completely, 100%. So I would always tell the patient, I can make it less obvious. So it would actually blend in with the skin.
So actually this is an imprint of the motherhood that should not be actually wiped off. That may be the reason God has not given us a complete treatment. So let it be there. My permanent should be there. Okay, then we can come to the facial rejuvenation. Now this is the new area now, because so far these conditions patient previously also coming to the dermatologist. But the facial rejuvenation now, the people doesn't want an older look now. And one of the questions from the colleagues, they asked in the group, because all the females in the group except myself and David, you all look so young, especially Jyothy during the MD period also she looked like this. There is no change, and Geetha became still more younger. So they are asking what is the secret of your maintenance of this beauty. So that may be the answer for the facial rejuvenation. So what are things you will do in your life and in other people? So Meera can start.
Okay, the thing is, like, cosmetic dermatology is something in which, like, okay, it's not just looking young alone, it's actually looking good, no? So now we have actually changed the concept to look happy, because what happens is with age, the mouth corners go down, giving us the sad, depressed looks actually.
Happiness is in the mind. That area I have to touch also.
Yeah, so looking good is actually like the better thing. So rather than just looking young, so it needs to be targeted in multiple ways. Like, okay, the skin, if we are worried about just the skin, we have to correct the textural problems with the peels or topical applications. But we all know, like, we develop wrinkles and folds and all this sagging with aging. So depending on what exactly is the problem, if it is a sagging, we need to use thread lips, which actually helps to tighten the skin. So the thread immediately passing through the tissue gives a firmness, plus it induces collagen formation, giving to that tightness. The wrinkles which develop with with expressions, the dynamic wrinkles we can correct with botulinum toxin. Then like the folds and the volume loss can be corrected with fillers. So I usually would say, like, okay, you have to go for a combination, and that actually helps to maintain. And the question sometimes people do ask is like, what is the right age for starting all these treatments? Actually, there is no such age. The moment you start noticing the things, you can start actually doing it, and you can maintain yourself. So you don't need to do too much. A person who has developed all the wrinkles and folds, and once they come to us, no, like, okay, whatever we do, like, okay, we cannot completely take away all the lines and things. Whereas when a person is going on doing the things, like, okay, they can maintain themselves. So that is what I do tell my patients, and honestly, that is what I also practice. Yeah. Okay.
So, Dr. David, can you just answer this question? What are the methods you will adopt in your practice to make the person looks young?
When you say rejuvenation, it is basically, it encompasses the color, the texture, the loss of volume, and all those factors. So if you're talking about color, the peels and the lasers, the Q-Systemic laser work. Texture, again, peels work, mesotherapy works, PRP works. When you talk about volume, you talk about volume loss and wrinkles, you give Botox, the fillers, the lipo transfer or the fat transfer, all the threads. So it depends on what area you want to tackle. And you don't treat a person in a single sitting. A patient comes to you saying that he wants to look younger, and you don't treat the patient in a single sitting. You give them a time frame by which you are going to plan all these procedures. You are going to do a laser first, you are going to do a peel first to improve the texture and color, then you are planning to give Botox, and then the fillers. If you can show improvement in a lesser or less costlier procedure, they are willing for a costlier procedure later. So start with cheaper topical agents and peels, then shift over to PRP, or then think about lasers, and then you go to Botox and fillers. So you want to give them a realistic plan that is in the next 2-3 years you are going to improve like this, or maybe in 1 year. It depends on the patient's need. A patient who is going to get married and they want a better looking face by the time they get married, that you have very short time frame, whereas an older person just wants an improvement over time, then you can give a longer time frame. So this is how I do it. I do the procedures.
Dr. Jyothy, what are the newer things in Botox injection you are using in facial rejuvenation, and also lasers and RF?
Botox, now the shift is towards micro Botox. So people are not like actually totally knocking out the wrinkles. So even if you are treating forehead lines, any part of your face, they recommend adding like micro Botox, like maybe 1 unit of botulinum toxin. You can inject it, so that you will have a better texture as well.
Any new Botox derivatives are you using, like long lasting Daxi, like something like?
Yeah, but that it has not come to our country, no. So we have to wait for that.
Then any regarding any RF or lasers in this?
RF radio frequency tightening we used to do. We used to do this thermage earlier. Then unfortunately our machine had some problem, so we stopped using it. But now again I think people are asking for thermage. After these many years, there is a trend shift towards thermage again, I guess. Then
HIFU is one thing.
yeah, HIFU is another thing. But HIFU, I don't know, like there are so many duplicate, not the original ones available. So the we can't be sure that the result of all HIFU machines will be equally good. But we can try. That is relatively like easier option when it comes to like rejuvenation. But the thing we have to remember is, see, we may be looking at a particular aspect on their face, but the patient may be worried about something else. So we should have a clear-cut idea like what the patient is expecting from us. So what I do usually is we give a mirror to the patient and ask them to point out the problem areas, so that we will know what they are looking for. What we are seeing on the patient's face may not be their problem. So everybody who is into this like cosmetology, like cosmetic dermatology practice, should have what they should learn first is the counseling thing.
So the
So
detailed
counseling,
patient evaluation,
that is the most important thing.
detailed
Like
patient evaluation is needed before the procedure, because they will be wanting something and you will be doing something, no?
yes,
So
and
anyway, the old
whatever
age
you do,
is,
they will not be happy with that.
so anyway, the old age is we can't completely cure, but we can prevent or arrest the progression a little bit. That is the only thing we can offer. So various procedures are there we can utilize according to the situation and depending upon what is the problem. That's the
Plus now the WHO has defined old age after 8 years.
yeah. That's
So
the,
we have to at least till 8 years we have to look young.
yeah. So this is the one I got, the Mona Lisa. Now she is going to America and residing there for 1 week. She will be like this. Actually, she lived in France. Okay. So, and this is the last thing. This is an androgenetic alopecia. Actually, these are the scalp of two famous dermatologists. So, what are the various ways of treatment you are, other than the surgery? Other than surgical therapy, what other thing you can do in this? Dr. Geetha?
In this, first we try to do find out whether androgenetic alopecia. I would like to go in for topical topical minoxidil. Then even you can start them on finasteride also, 1 milligram per day. You can watch for the progression and continue it for at least 1 year or so.
So if you're starting finasteride, will you give a prior permission to the patient discuss the
No, I'll have to discuss all the complications of finasteride. And
what
the better
percentage
than
of patients are willing to take finasteride?
many. I usually the dose which is very complicated is about 5 milligram. We can consider 1 milligram is homeopathic dose also, like tranexamic acid.
Well, after counseling, how many percentage of the patients will be happy to receive finasteride?
Not many, sir. Not many.
Problem.
Most of them are not willing to, because the side effects when they hear, most of them are not willing for.
Then how will you proceed?
Then no, sir, I don't proceed. Then I would prefer to do also the PRP with microneedling.
So, Meera, what is your experience regarding PRP and other mesotherapy in androgenetic alopecia?
I don't do PRP because I do a lot of mesotherapy. So comparing the two, I have found mesotherapy giving better results than PRP. So nowadays I have stopped doing PRP completely, but I do mesotherapy. There are so many stem cells and growth serums and that kind of solutions available, which actually when we do the mesotherapy give fantastic results. So I do it at 6 weeks intervals and in 2-3 sittings. Even with a single sitting, I get very good results, and I would continue it like for 2-3 sittings at 6 weeks intervals, and then may do a maintenance day.
So, Jyothy, will you give a solo therapy or you will combine multiple therapies in androgenetic alopecia? What's your mode of approach? Like microneedling, PRP, mesotherapy. What's your mode of approach?
No, I go for procedures only if the patient is not responding to medical management. So instead of PRP, now this growth factor concentrate has come. So instead of injecting platelets into your scalp, you take out the growth factors from the platelets and then inject. So that solution will have 0 platelets, only the growth factors will be there. That is one option. But whatever said and done, this picture what you have shown, I don't think any of these modalities will work. In advanced stages of AGA, I don't think there is much hope for the patient.
Dr. David, only you are the only hope for my and our scalp. So what you can do on this scalp? You just tell us your mode of approach in this case.
Yeah, you talk about surgical modality and topical modality, or the conservative modality. Basically, these are mutually exclusive. So you have to treat, even if you're patient is planning to do a hair transplantation, you have to treat the patient for the residual hair. It shouldn't progress further. So the mainstay for me is minoxidil, topical minoxidil and finasteride. most of my patients are willing for finasteride intake or tablet. What I tell them is, I'll give you finasteride till you show good improvement. Then I'll make it weekend therapy, like Saturday and Sunday, they'll be taking finasteride tablets. And the rest of the days, they'll be using minoxidil with finasteride solution. And then once they get a good result, maybe after 1 year, I'll just make them maintain with the minoxidil finasteride solution. And there are patients who don't respond to this modality. Then I think about oral minoxidil with finasteride. So that is another thing I try. And there is one area where you start procedures early. Like in a patient, young patient, 17-year-old coming with grade 3 androgenetic alopecia, grade 2 androgenetic alopecia, he'll have to use all these medications for the next 30, 40 years. So in these patients, the treatment should be a procedural therapy. And you can discuss with the patient. If they are willing for a procedure, you do the procedure first. And it is enough. If that is enough, PRP is enough or Regenera is enough, then you just maintain with that. Because patient need not apply the solution. And in this age group, they don't apply or they don't continue using it. So that is one area where you do the procedures first. But usually you start with a topical or systemic therapy, then you shift over to PRP or Regenera. And for correction, after doing PRP or grade 3 androgenetic alopecia, there is some recession of hair left behind. They can do a hair transplant to correct that. So that is how I tell the patient.
These procedures, other procedures other than hair transplantation, what is the result of the durability of the result? If you are doing mesotherapy, PRP,
PRP, the results are very variable. So some patients get a very good result and some patients don't get that sort of result. So to improve that, you can use PRF, which has a slow release of growth factors and a longer lasting effect. So you can use PRF or the micrografting or the Regenera procedure. Regenera shows good result for 1 year and maybe a little longer than 1 year, and then it starts waning off. So you have to repeat it again.
That's the problem. We will have to repeat the procedures again and again. So all these conditions, that is the importance. By single sitting or in one session, the durability will not be that much long. Okay.
This low dose oral minoxidil, what is your experience?
I use 2.5 milligram to 5 milligrams. So 2.5 I used to give. And most of the patients don't show a drop in BP or changes in don't show any side effects. So it is better than topical minoxidil, but it's not a big improvement. You talk about 5% minoxidil or 10% minoxidil, it is better than that. And most of the patients I have given is male patients, not female patients. You don't want, I don't think there is an increase in the body hair per se, but I don't want to risk it.
Which are the brands available, David?
Minogain.
Incas
yeah.
has one. Incas has
I used to use routine tablet, so that is 2.5 milligram.
If nothing works, a tattooing or micropigmentation can be done.
Yeah, that's another thing you can. That's how the bald areas.
Camouflaging.
Yeah. So regarding this mesotherapy, especially now the injection glutathione that is highly discussed, and there are so many controversies regarding that. So what's your opinion, Meera?
About injection
glutathione.
Injection glutathione, the thing is like I do give injection glutathione, that is they are given us slow IV injections along with vitamin C. For some patients actually it gives good results, for some patients it doesn't produce any change. So there are like lots of the thing is like the fairness fad is huge, so people do come asking for it, so we cannot actually completely avoid that in our practice. So the only thing is like how frequently we give the injections. So some patients do take it that actually depends on their budget and their pocket. So there are patients who take it weekly, there are patients who take it at 10 days intervals, there are patients who take it at monthly intervals. Some patients even
side effect profile.
Till now, I haven't found any side effect with the glutathione injections. But
certain reports of hepatic complications, neurological problems, and all.
It's very rare, very rare.
Anybody else are using? Anybody else in this group are using?
I have seen two like urticarial lesions following glutathione.
I don't give. I give oral
What's
now.
the
Oral
result,
glutathione.
what your experience?
How many vials per sitting do you give, ma'am?
Pardon?
Per sitting, how many vials?
How many vials? Usually, like, okay, that again depends on the patients. Like, okay, so for some I give it 1 vial, or some 2 vials, or maximum 3, not more than 3. I don't.
So what's the result you are getting?
That's what I was telling, like, okay, it's very unpredictable, because some patients, even with a single vial, single dose, they get very good results. For some, even after like multiple injections, we don't get any results. So I think it's depending on their body metabolism. So depending on their body metabolism, the amount of the cumulative dose of glutathione is something which actually determines how much effect we are getting. And that definitely varies from person to person. And I do tell the patients, because for some it works, for some it doesn't work, for some even with the oral glutathione we get very good results. So that varies. I haven't, the sublingual preparations have been available. So they claim like, okay, the sublingual preparations also would go well, but I haven't found any result with any of the sublingual preparations. But the some oral glutathione and the IV, I have found good results.
So this
At
is
least
the last
it will improve the energy levels.
Pardon?
It will improve the energy levels. Ultimately, it is an antioxidant. So we have a few patients who wants to have glutathione for improving the energy levels.
So this is the last question. Means which are any other patient seeking procedures commonly coming to you nowadays, other than the area we discussed?
We have this CM Slim, that shortest way to get 6 packs.
For body contouring.
Yeah, body contouring, that electromagnetic induction therapy.
So these are the now people are opting
then
for
microblading, lip
Microblading
blushing,
and the lip
these two.
pigmentation is very common. Everyone wants eyebrow tattooing and microblading and the pigmentation of the lips these days.
And so then there is another treatment called hydrofacial, which is
again,
that
is the in thing.
So everybody wants a hydrofacial. So
even though it's an old treatment, it has recently became so
that is
popular.
because of the Instagram these days. Insta, everyone is into the hydrofacial part.
The Instagram and social medias, that is a good hope for the cosmetic dermatologists, I think. So we should promote it. So okay, anyway, thank you for the panel, for the very interesting discussion, and all of the panelists that you have participated well, and I hope the audience have got some insight regarding these new areas. So thank you for the participation, and this is the last program, and by this we are going to wind up the session. And I want to give a vote of thanks for all the people who are attended this program. Especially there was a long effort behind this very successful program. Many days, we are up to 3 or 4 months. We started our meetings, and last for 1 month we were very busy. Especially this is a new area. So far we were conducting the program offline, so we are not that much friendly with this type of online program. So we were very busy, and we were doing very hard work for last many days and last 1 month. Especially from our department, Devi Madam, she guided us, and she was a very good leader. And by her able leadership, we could conduct this program very nicely. And also all other faculties, especially Dr. Shivan, Dr. Rahima, and Dr. Bindu, Dr. Sarida, Dr. Ansa, Dr. Sapna, Dr. Jishna, and Dr. Reena, and everybody participated very well in the arrangement of this program. And also our SRs and JRs, especially Dr. Latheef, is the only one male in the department. And one more here just passed. So he as the natural things, the male will be overburdened. So he is doing all the many of the area. So many of the days he is doing very hard work, and all other JRs, especially Dr. Lenny and Dr. Reshma, the compeers. So everybody have done a very wonderful job. And also all the faculties and teachers who gave, especially Sophia Madam, she agreed to give the oration. And all the teachers we consulted, Sugadan sir and all the teachers. So they were very, very happy to the recording and very interesting in helping and advising in all areas. So I thank everybody and especially all the participants. And I think more than 100 participants are there throughout the program. So they have absorbed the spirit of this program. So this was a very wonderful and I think it's a very memorable program. So I thank each and everybody who have contributed, and especially one word regarding Samad sir. So actually he was here during the initial phase of this organization, but later he transferred to the Alapi and he was actually to moderate this session. Then on his absence, I have to do this program. So I thank each and everybody for their cooperation and their guidance and their help in making this program a grand success. Thank you. Thank you very much. So by this, we are winding up this session program.